Okay, yeah, good afternoon, everybody. Thanks very much for showing up to this, the second REACH network meeting. Just a few introductory remarks before we get on to Professor Cathy McHugh's presentation today. I'm Robert Scully. I'm based at the University of Galway with my colleagues, Michelle Canavan and Honor Griffin. We're running this network meeting. A few points for those of you who weren't here at the last meeting. Well, you're very welcome. The rationale really is to recognise that those of us who work primarily as clinicians outside of major cities have different educational needs and actually networking needs than those colleagues who work within the cities. And core to this really is the use of enhanced clinical generalism in our day-to-day clinical practice. We, as you know, we're establishing a graduate program at the University of Galway, and we want generalism to be core to that curriculum design. And as such, we decided to establish this network to celebrate generalism and start to present it to students particularly, but also to ourselves as a recognised skill set that's really critical to embed in our daily practice. And the other thing then is interconnectedness. We're not working within large healthcare ecosystems, so really how we interconnect with one another is critical to providing patient care. So, we're really delighted with the REACH network. We've 350 people registered. You can see there on the left-hand side of your screen a really nice distribution between our primary and secondary care colleagues and our health and social care colleagues and nurses and others, and hopefully the others are particularly trainees and students, and a really nice mix actually from geographic location across rural, urban and suburban locations. So that's really fabulous, and we're hoping to build on that over the weeks and months ahead. Housekeeping, so this is a virtual meeting. We are planning an in-person meeting or network event hopefully in the first half of 2026. And before we came on the call, we were chatting with Cathy, who's leading today's presentation, and we felt that would be a really important networking event, networking opportunity. These meetings are recorded and we'll be publishing them. The presentations go on for about 40 minutes, and there'll be an opportunity then for questions at the end. So we would ask you to use the chat function and we'll moderate that, or raise your hand. And really appreciate if you can put your camera on, and if possible, if you're asking a question, because it's a bit of a lonely place to be a presenter here and not see anybody's face. Thanks for muting your microphones. The CPD hospital buddy code, I believe, is 8787, and we'll have other CPD for GPs and other has been applied for, and we'll get in touch with you by email about that. As I mentioned, we're championing clinical generalism, but we're open to suggestions, and you can contact us at that email address, reachnetwork@University of Galway, or use the feedback form, and Honor will put the feedback form in the chat during this meeting. Really appreciate if you can engage with that. Just a disclaimer, the information that the speaker is providing is obviously intended to be as accurate as possible when the talk is given, but this presentation doesn't replace clinical guidelines. It should not be used as such. You see Cathy smiling there. Really briefly, our next session, we're gonna break for December because of the silly season, but we'll be meeting on the 14th of January, and delighted that Dr. Scott Walken from Ballina will be delivering, and works with Amric, will be delivering a talk regarding antimicrobial stewardship. I'm not much of a Gaeilgeoir, but Níonhearcaigh Curla Chéile, there's no strength without unity. So that's something for your diaries, and we'll be in touch. But you've informed me the CPD code from last meeting. Yeah, Mark, we can do that, no problem. So to today's speaker, Professor Cathy McHugh, many of you will know, works in a Model 3 hospital in Sligo University Hospital, an endocrinologist, general physician, really heavily involved in training and leading on various aspects of training with the RCPI, and leadership really amongst our physician colleagues. To deliver a really fascinating talk, which I'm sure we're all interested in, burning questions for the endocrinologist, an update for the generalist. So, Cathy, I'll stop sharing and hand over to you. Thank you.
No, I took off my mute. Thank you very much. And welcome everyone. You're very good to give your time. Now, can you see, if you give me a thumbs up, Robert, if you can see my slides. Okay, now just as I do this, my computer starts flashing to say that my internet connection is unstable on the labs. So if it freezes, I apologize. It is a HSE special. All right. So I've just picked out, I suppose, my commonest referrals. That's really, it's hard to know where to pitch these kind of things. So that's pretty much what I've pulled out. It's only just a tidbit. I'm not going to teach you everything there is to know about endocrinology. Well, A, if I knew it, would be that I'm not going to teach it in 30 minutes. So I just did the commonest referrals and a few tips. I think is possibly the easiest place to start, if that's okay. And now I want this to move forward. There we go. So I was going to do a bit about thyroid, I'm going to do a bit about steroids, and a bit about prolactin. I thought there will be probably my commonest referrals in my endocrinology clinic. So I suppose my first guiding principle. Now this applies to any aspect of medicine. Don't measure it if there's no indication. Do not go looking for trouble if it is not looking for you. And I think endocrinology is a prime example of this. If you find yourself ordering more than 5 hormone tests, then you're on a fishing expedition. You need to pull on back and go, lads, I need to hone this down a little bit. That is the endocrinology funny one. If you start measuring stuff, well, this applies to anything. If you start measuring stuff that really is not clinically there, then you have a whole load of abnormal tests with no clinical indication, and then you're in a right pickle. So if you don't think it's abnormal, don't measure it. That would be my tip if you took nothing else away from this. Okay. So let's look at the thyroid. Starting now, I suppose the first thing I think, which is quite useful bit of information, is that the free T4 takes 2 weeks to change. So if I make a dose adjustment now, it's going to take 2 weeks before that T4 is going to reach where it's going to reach on that dose, for better or worse. So if I'm measuring the bloods today, there's no point measuring tomorrow, and there's no point measuring the day after. It's not going to have time to change. It is going to take 2 weeks, and the TSH is going to take 8 weeks. And the TSH, to refer to it, is probably a better marker than the T4. It's a better assay. It's your own internal sensor. So if you can wait for the 8 weeks, good and well. If not, 2 weeks for your T4. So the times I would use the T4 would be, say, someone who comes into me with a T4 of 100, and the normal thyroid function test would be less than 22. So they're 5 times above normal, and they're pulmonally thyrotoxic. And I'm pitching a dose of carbimazole to treat it. And this is a conversation I have to have with the patient, to say to them, this is not like aspirin where everybody needs 75 milligrams. This is a drug that everybody needs a different dose. So I'm going to pitch it a middle of the road dose, and then I'm going to go up or I'm going to go down from there. I think it's an important conversation, because otherwise I feel the patient goes away and thinks, geez, that one doesn't know what she's talking about. Today she had me on 20, yesterday I was on 40. So I think it's really important to get them on board to know that, this is, you're going to pitch it somewhere, and you're going to go up and you're going to go down from there as the weeks move on. Generally, now you won't get this in the guidelines, I will say that up front. Generally, if it's an elderly person, I'll start them on 5 milligrams of carbimazole. If it's a younger person, I usually start them on about 30. That would be my starting gambit. So if you come into me with a T4 of 100 and you're wildly thyrotoxic, I'll start you with 30 milligrams of carbimazole. And you take it once a day. Now the BNF does say twice a day. It doesn't actually need to be twice a day, and it's very hard to remember to take it twice a day. So I would recommend giving it once a day. I would then get a blood test on you in about 2 or 3 weeks' time, and that's just going to tell me if I'm anywhere remotely near the ballpark. Am I anywhere at the races here, or am I wildly off? So if I put you on 30 and in 2 weeks' time it's still 100, then I'm thinking, right, well, I haven't even got anywhere near this. I'm going to need to crank this one properly up, and then you're going to find yourself on 50. That said, if it comes back a really low and I've overshot it, then I'm going to pull it back. All right. So if I've overshot it, well, in this particular instance, right, let me move on. A T3, other thing. Hardly ever do we need to do a T3. There's one instance which I'll talk about in the next few slides where I do a T3, but actually hardly ever. It's quite an expensive assay, and from us it has to go to Galway, so it does take time to come back. So I hardly ever order any of them. I think I order probably less TFTs than most people. You find on the general wards we have all kinds of issues with TFTs. They get measured when they come into AAU. When the GP will measure before they send them into us, we get measure another one in AAU that day. They might get another one on the ward the next day. They get another one in 2 days' time. So lo and behold, we have 5 samples of TFTs all within the one little window. So 2 weeks for T4 and 8 weeks for TSH. I think it'll then reach where it's going to reach. Because if you do it in the middle, there's a risk you're going to get it on the way to somewhere. So if I measure your TSH in 4 weeks' time, we'll say it's 5. I mean, is it going to settle at 5, or is it on the way to somewhere else? And I won't know until I wait the 8. So I would usually give people an appointment to come back see me in about 3 months-ish. Gives them time to make an appointment, to get the bloods taken, to get the bloods, to get the result, to get the appointment letter, to come back in. That's usually my kind of window. Right. So the other thing is if you find that you put, so somebody, I think I might actually have an example. Here we go, Maria, that's my next one. Who would say she's a 45-year-old lady. She's initially diagnosed with free T4 of 89 and a TSH less than 0.01. So she's probably thyrotoxic. She's a good go in thyrotoxic. She got her tremors or insomnia or palpitations, sweating, blah. God starts her on 30 milligrams of carbimazole. And over the next 6 months, things normalize and things settle down quite nicely. And then you find 6 months later, she's gone over a cliff on me and her T4 has gone down from 89 down to 4.9 and the normal is over 12. So she's clearly gone over. So she's over carbimazolized, if that's actually a real verb. It's not a real verb, but she's over suppressed, really, is what she is. So at that kind of instance, what I normally do is I normally stop it for 2 weeks, let the thyroid come back up again, and then restart at a lower dose, something like 15, 20, something in that ballpark, just to pull back on it. Give it 2 weeks, because the reason I pick 2 weeks is you have 2 weeks of stored thyroid hormone in your thyroid. So, and the carbimazole will stop you producing any more. So that 2 weeks is your kind of 2 weeks window. So I would stop it for 2 weeks and restart at a lower dose. And then what I would do, I would probably measure it again in about 8 weeks' time. That would be the 8 to 12 weeks. That would be what I would measure and see where that TSH has set on that 15. I mean, all I can say when she's on 30 and she's over suppressed is that what she needs is somewhere between 0 and 30. I can't really say with any more accuracy than that. And I say that to the patient. I said, right, well, you need between 0 and 30. So let's pitch it at 15 and see, and we can really go up and down from there. So that will be the 2 weeks to stop it for 2 weeks and then restart it lower. It's very useful. It gives you a little bit more of a gauge. Right. The other thing I would say about thyroids is that very few people need a thyroid ultrasound. And when I started here, I got pulled into radiology, and the question that I was asked was now, because I was the first endocrinologist here. And the only for a long time. And the question was, oh, are you going to put a big demands on our service, Dr. McHugh? Well, actually, I think I know I actually ordered less thyroid ultrasounds than most other people. Very rarely. The indications for thyroid ultrasound will be a palpable nodule or some of the history radiations are neck for whatever reason. They'd be more likely to get a thyroid carcinoma. For a thyrotoxicosis is not, I mean, I wouldn't, and I have a gallstone, and I would never, I can't see now with the jumper that's on me, but I would never, I wouldn't ultrasound it. What I'm doing is I'm then going to find out that I have, I don't know, 5 nodules, and one of them is bigger than the other. And then somebody's going to say, oh, you need an FNA for that one big one. So then I have an FNA, and I get an indeterminate sample. Then I have another FNA, and it's another indeterminate sample. Then I end up with a biopsy, and I'm going down this rabbit hole for something that I didn't need to be in the first place. So I would only really for a palpable nodule that I order thyroid ultrasounds, because it is very tricky, and you end up with a lot of anxiety, and you end up down a rabbit hole you don't really need to be down. Thyroid antibodies are the next thing. Now, I wrote down here they're next to useless, not completely useless, but they're not a million miles off it. A really common referral that I would get in is that somebody's measured somebody's anti-TPO antibodies and it's 200, and then they measured in 3 months and it's 400, and then they measured and it's 300, and it's up and it's down, and it's like, you know, what do I do with this? Well, firstly, what measure in the first place is what I would say. The only really useful one is a TRAB antibody. The TRAB antibody is for Graves. You think someone genuinely has Graves, that's your antibody. Every Tom, Dick, and Bloomin' Harry on the street has an anti-TPO on the slide, and it'll go up and it'll go down, and it'll go up and it'll go down. And even in the setting of thyrotoxicosis, I don't usually measure, to be honest with you. So I'm going to treat it with carbimazole for 18 months anyway. And it's not going to make any difference to me really of any Graves nature. If I really think it's Graves, I might do a TRAB. And the things that would make me think it was Graves would be the thyroid eye disease and the preceding myxedema. They'd be what made me think it was Graves. Otherwise, it's probably Hashimoto. It doesn't really make any difference. I'm going to treat it the same anyway. And I would definitely say that if you do not have any symptoms, definitely don't go measure the TPO, because then you get a positive, and now you have someone who's, oh my God, what am I going to do with this? So I really would, it's not useful for routine screening. And monitor the level.
Right, isn't it? But I think they won't advertise the fact. I'm sure word will get out soon enough. They go,
one second, we try and mute that person. Right.
Somebody there, sorry now. Right. Now, there are, now to be fair to it, after be saying that they're next to useless, there are a couple of circumstances where I do use them. One is a subclinical hypothyroidism. So that's your person who has a free T4, which is normal. So then, and the TSH is 5 to 10. So the TSH is gone off, but the T4 hasn't followed suit. That's your kind of borderline. Will I treat, won't I treat as a hypothyroid person? That's your in-betweener. And the guidelines would say that if the TSH is between 5 and 10, if the thyroid antibodies are positive, you treat them as an underactive thyroid. If they're not, you watch and wait. If they're over 10, crack on with it. See, then you're starting someone on thyroxine. Usually an elderly person, about 25 milligrams, or micrograms, should I say. That's an older person. A younger person, a full adult replacement dose of thyroxine is about 125 and 150. So if they have a TSH of 80, then I'm not going to be messing. If you're 25 years of age and you have a TSH of 80, I'm not going to be messing around with 25 micrograms and titrate up. Just go for it. They need 125, they need 150 off the bat. If they're older, then I think it's reasonable to start at 25 and titrate up. You don't want to precipitate ischemic cardiac event or anything like that. But your in-betweener ones with that 5 to 10 TSH and the T4 is still okay. They're the ones you need a thyroid antibody on. If it's positive, crack on and treat them. And you treat them as any hypothyroid person. If it's not, watch and wait. And I would suggest annual TFTs. That's what the guidelines would suggest, annual TFTs for that. The other time we use thyroid antibodies for pregnancy. Any pregnant woman that comes my way, I would do thyroid antibodies. Now, particularly the TRAB, because that's for someone with Graves' disease. Those antibodies, when the baby's in utero, those antibodies can pass to the baby. When the baby's born, it takes about 6 weeks to break down those antibodies, and they can go transiently hypo or hyper, but classically hypothyroid during those 6 to 8 weeks after the baby's born. Now, what they describe is a baby that's slightly more irritable than any other baby. Now, I have 2 babies, and I don't know how you distinguish irritable. They were all irritable. I don't know how you distinguish that from anybody else. I have no idea. And I've been doing this since I started here in 2008, and I have been doing this. I've been following the guidelines. And when you're single-handed, you certainly would follow the guidelines more than any other time. I've been following them, and I've been getting them on all my pregnant women, and I have had plenty of them with positive thyroid antibodies. And so far, we have had 0 babies who are hypothyroid, other than a baby that's actually properly hypothyroid and will stay hypothyroid. This has happened in 0 cases, so it's not a big runner. But I do them in pregnancy. I am a good girl. I do them in pregnancy. Other time I do them is sometimes postpartum. Postpartum, about 10% of women will experience a thyroid surgery or a thyroid abnormality, I say, in that year postpartum. And it usually settles after the year. So if someone comes into me and they're thyrotoxic postpartum, so my question that's going through my head is, right, well, are they actually a proper thyrotoxicosis who just happens to be in a year postpartum and it's just chance and they're going to be a proper thyrotoxicosis? Or are they going to fall into that postpartum thyroiditis that you get postpartum that will disappear in the year and actually is a destructive process and doesn't need carbimazole? So for them, a TRAB can be useful. Because if the TRAB comes back positive, then I'm more likely to think they're proper grades and I'm more likely to give them a carbimazole, more likely to treat them, more likely to continue on treating after the year. Other guy, I'm thinking, don't know if this looks more like just a postpartum thyroiditis to me. I'm going to sit and watch and wait this, unless you're very symptomatic, in which case I'll probably use just a beta blocker. But unless you're dancing off the walls, I'd probably just watch and wait and listen. And after 12 months' time, it should settle. Now, if they are dancing off the walls, you can put in some carbimazole. But just be watching for that year. When it comes to that year, you're going to stop needing it. So it's just you'll find they go under on the dose they were previously on. So that's really the only time I use them. For routine screening and asymptomatic, otherwise well people, then they're actually just going to mire the waters more than anything. Right. That's a couple of scenarios. So let's say I present to you and I'm on thyroxine, 200 micrograms once a day, multivitamin. I feel well, and routine follow-up TFTs show you this. Now I would see this in clinic all the time. So the T4 is actually a little bit on the high side, but the TSH is 23.5. The TSH is high. So you have one saying you're a little bit over, and you have one saying you're a little bit under. Now, what happens, certainly the most common thing that this will do in my clinic, or that will happen in my clinic, is that someone's not taking the thyroxine. And they get a letter from me to say they're coming into clinic and they go, oh, holy moly, I better start taking that thyroxine. This one's going to get really angry with me. So they start taking the thyroxine. They get an appointment for my clinic 2 weeks out. So they have 2 weeks before clinic to start taking the thyroxine. So the T4 has had time to go where it's going to go. The TSH hasn't had time. It's a bit like HbA1c. It tells a more longer term tale. So I'm sitting there thinking, A, you're probably on a little bit too much anyway. But B, you haven't been taking this. And you've started pulling your socks up now with 2 weeks to go. So the T4 is gone where it's going to go. But the TSH hasn't gone where it's going to go. So I'm having a compliance conversation. That's the first thing. Now, to be fair, before I take the head of them, this person is on a multivitamin. And a multivitamin often contains iron. And if you take a multivitamin at the same time as you take new thyroxine, you can stop the absorbing of thyroxine. And sometimes you find that when they change multivitamin with no iron in it, the thyroxine will start to be absorbed. So I would suggest taking the thyroxine, having it on the locker. When you get up in the morning, taking it straight away. So then you get up, you have your shower, you dry your hair, you put on your makeup, you do whatever you do. And but it's at least half an hour is gone before you're actually sitting down eating. And then you take your multivitamin. You leave that half an hour before food. And you leave half an hour between your multivitamin and your thyroxine. To be fair, so before I go accusing anyone of any non-compliance, that would be my starting point. And also gets me around the non-compliance. I mean, I would say to them usually if a conversation goes, it's one of two things. Either you're not taking this tablet, or the multivitamin or the meal is interfering with this tablet. It's one of the two things. So I'm giving them an out, but they have recorded the fact that I have thought of it and they have thought of it, and it's out there. It's a non-compliance issue. But it's just something to consider. To be fair, the multivitamins and iron and food does interfere with the absorption of thyroxine, so it should be taken on an empty stomach. That's the take home. Right. So let's move over to this person we have over here. I just have to move this. Sorry, now I need this on your screen, but I have the screen with all the people's photos on it. Just over that. So somebody say I go into and I'm not in any meds, and it's just an incidental finding, it's just a routine check. I'm not pregnant, and this is the blood test that comes up with function. So you're looking going, oh my lord. So there's a few possibilities for something like this. So the T4 is in the normal range, and the TSH is low. So there's well, a couple of things going on. One possibility is that this person is taking thyroxine in the background. And it wouldn't be the first person to take thyroxine to try and lose weight. It does make you lose weight. It's actually working to lose weight very well. Particularly if you take too much of it. What it will do, I've had a number of people come into me in the past day from taking thyroxine to try and lose weight. Now they look beautifully skinny, but they're bouncing off the ceilings and their heart rate is 180. So that's one possibility that they're taking it. If they were on thyroxine, then I'd be worried that they're taking too much thyroxine, but this person isn't. There's other than that, there's three possibilities. One is a T3 thyrotoxicosis, and this is possibly one of those really, really few instances I'd ever do a T3. That is a T3, because if your body breaks down T4 to T3, so if you have a T3 thyrotoxicosis and you're measuring T4, you won't necessarily pick it up because you're not measuring it. So it won't go back up that pathway. So you find the T4 is actually fine. If sometimes it can even low. So that's one of the instances worth measuring T3. It might be that they have a T3 TSH deficiency. That no matter what you do with them, all the carbimazole in the world isn't going to make this contribute to make TSH. So their pituitary gland just doesn't make TSH. And that I would see quite reasonably commonly, pituitary TSH deficiency. Now, in that kind of an instance, you really need to send them into me because I need to do some little stimulation tests to see what the other pituitary is doing otherwise. And there's a few different tests I need to do in this kind of a person. So that's your other possibility. And your third would be subclinical thyrotoxicosis. And that's probably what most is. That is what most people fall into. It's most likely a thyrotoxicosis. But TSH has gone, but TSH hasn't quite gone yet. It will go, and it'll go in due course. And the recommendation is that you treat this like you treat any thyrotoxicosis. You treat it exactly the same because it carries the risk of atrial fibrillation, it carries the risk of osteoporosis, which are your main risks with an ongoing thyrotoxicosis that's untreated. And so they probably need to see me, whereas the first guys need a serious conversation. These guys need to see me. Now, let's look at the other. What a really common presentation that I get on is the box there on the bottom is that 10 weeks gestation one. This would be extremely common. I would get a significant number of referrals from this. So people in early pregnancy have a really high HCG. Obviously, that's part of being pregnant. If you have hyperemesis gravidarum or a twin pregnancy or anything like that, you have even more HCG. And HCG, certainly one end of it, looks very, very like TSH. And it can stimulate your thyroid, and your pituitary can read that. And your pituitary can often push down the TSH because the HCG is stimulating the thyroid enough. It doesn't need any more push, so the pituitary just turns itself off. It's a normal part of pregnancy. It's not harmful, and it generally subsides as the pregnancy goes on, when the HCG levels settle. Now, sometimes it doesn't, and it still lasts the whole pregnancy, but it is no harm. The T4 is not running riot. The pituitary has switched off the tap and is letting the HCG just drive the T4, but actually it's doing fine. So it does not need any treatment. It just needs a watching and waiting. That's all it needs. It's that gestation thyrotoxicosis, what we call it. It's not a true thyrotoxicosis. It's the HCG stimulating the thyroid, looking like TSH. That's what that is. Right. Okay. Let's change tack. We change tackling to steroids. We move off the thyroid altogether. Now, this would be another one that I would get, not from anyone really. And with the number of people on steroids is going, it's not necessarily going up, to be fair, with a lot of the new immunosuppressants for ulcerative colitis and Crohn's and rheumatoid arthritis, not maybe as many people, but certainly in primary care, you do people for polymyalgia rheumatica and COPD and various bits and pieces like that. So there are still people knocking around on steroids. And one of the biggest things that happens in here, unfortunately, is that when somebody's on, we say 10 milligrams or 5 milligrams of pred for polymyalgia rheumatica, and they don't double the dose up for the sick day when they're in here, but that I will talk about in a minute. Right, let me look at Neve. Now, this is not Neve's picture, it's a picture I downloaded on the internet. But Neve actually is actually a real person. She's 46 years of age, and she's on steroids for 24 years from sarcoidosis. And God help her, she has blown up like an absolute beach ball, and she's only young, and it's a real problem for her. And the steroid dose has been up and it's been down, it's been up and it's been down. And every time we get it down, it goes up again for the sarcoidosis. So it's a bit of a battle. And it's awfully hard on her. It's really tough. So at the minute, I saw her there a couple of weeks ago, she's on prednisolone 10 milligrams. But now her BMI is running at 36. So they're taking their toll, to be fair to her. So there's a couple of things. It is consultation like that I'd be considering. Now, let me just say this first before we do anything else. The steroid conversion, the 5 milligrams of prednisolone is your physiological dose. That is the amount of prednisolone that's in you and I as we sit here right now. That's the amount of steroid, should I say, that's in you and I right now. That is the floor. If we go below that, we're asking the adrenals to kick in and supplement it back up to that. So that's the floor. That's equivalent to 20 milligrams of hydrocortisone orally. So someone who's got Addison's disease and is on replacement hydrocortisone will be on 20 milligrams is probably plenty. It's probably plenty. Divide over what we did, but that is probably plenty. It's equivalent to only 0.75 of dexamethasone. Excuse me. So if you look at the doses that are used in oncology, where somebody's on 8 milligrams 3 times a day dexamethasone, it is a dose that makes my eyes water. It really is just huge doses. But prednisolone, 5 milligrams once daily, equivalent to what you and I have in our ordinary everyday lives. So anything below that, you need your adrenal glands to be able to kick back and do something. So once off steroids, like we say, a joint injection. I have had people who've had to suppress cortisol after that. They're generally not symptomatic, and it usually only lasts a few days to a couple of weeks, and then it disappears off. So it doesn't need any treatment. It usually comes back. But I definitely have had people after one-off injections who've had to suppress cortisol, but just ignore it. I wouldn't even measure it, to be honest with you. Short-term use, I would consider less than 3 weeks. Longer-term use is over 3 weeks. And the reason I'm saying short-term use is that if you're on steroids for 3 weeks or less, there's very little risk of adrenal suppression. You don't need to take them. You can just stop them dead. Doesn't matter if it's 40 milligrams for 3 weeks. If it's 100 milligrams for 3 weeks, you can stop it dead. You don't need to taper it. It's only prolonging the effects. Now, that said, if you're on back-to-back doses and you're up and you're down, you're in and you're out, that's maybe slightly different. And dexamethasone is the longer acting steroid than prednisolone, so it might take a little bit longer to get out of the system. But by and large, for prednisolone, less than 3 weeks. So your COPDs or your asthmas, those kind of people, where you're putting them on 5 days of pred, you can put them on 30 milligrams 5 days of pred and then just stop. You don't need to take them. It is worth talking to them about the increased appetite, the fluid retention, the sleep disturbance. Now, whether you're going to sell the drugs to them at this point in time after you go through all this is another issue entirely. If you take them past 5 o'clock in the evening, they're going to make you stay awake. They're going to stop your ACTH drive, and it's very hard to sleep on them. The appetite is certainly something you need to watch. I think it's really important to warn them, because if you don't, then they'll just because I'm hungry, they'll keep eating. If they know it's going to do it, and it's the drug doing it, you've got some chance of them holding it. But it's very hard to fair. It's very hard. And if you're on like Neve for 24 years, a long time. And then the inhaled corticosteroids giving you a bit of thrush and give you a bit of hoarseness. So it's just to take a drink of water after you take your steroid inhaler. Even though we're using less and less steroid inhalers than we were, but it's the conversation with the patient. If they're with you and they're on board with you, it just makes those ups and downs a hell of a lot easier to manage. Right, so that's short-term steroids. That's less than 3 weeks, no taper. We'll go in the wrong direction. Over 3 weeks, if they're on 5 milligrams of pred or more, or an equivalent of 5 milligrams or more for more than 3 weeks, then you're probably going to have to. Then you are going to have to taper. Now, if it's 3.5 weeks, fair enough. But if they're on it for years, like me, then you're going to have to seriously taper. The symptoms when I'm tapering people off steroids, I would say I'm very honest with them and say, you know, I don't know if I get you off them, but I would certainly try. I'm going to go down really, really slowly. And if you're not feeling right, go back up to whatever the previous dose was. And we'll come down again a little bit slower. Or we might need to slow down as we go down. And then you might be fine and you might be rocking on with it. But give them a little bit of autonomy in it. But I'd say absolutely 5 is the floor. When you get to 5 milligrams of pred, then you need to sit in front of me. We need to be going super duper slow past that. Because that's when I need your adrenals to kick in. Up to that point, I am happy for you to bring it down. But at that point, I need your adrenals to kick in. Okay. Your sick day rules. Now, I think endocrinologists are for everyone about sick day rules. We have sick day rules for diabetes. We have sick day rules for SGLT2 inhibitors. We have sick day rules for steroids. So we love our sick day rules for these. And the people with Addis and stuff get sick of me having the same conversations. If you know your sick day rules, you stop sure we did it last time. You can't say it often enough. If you're on 10 or less, because 5 is the floor. If you're on 10 or less, you need to double your dose. If you're on 40 milligrams of pred, you don't need to be doubling your dose if you get sick. And I would say sick enough to take to the bed. If you're sick enough to take to the bed, I would generally say you double your dose for 3 days. Sick enough to take to the bed, double your dose for 3 days. Now, if you're on 40, you don't need to be doubling up to 80. 10 is plenty. But if you're below 10, you definitely need to double it up for 3 days until you're well enough. Now, if you're vomiting and you can't keep it down, then what you need to do is you need to either get an antiemetic, go to your GP and get an antiemetic or something to keep it down, or try your best to keep it down, or you're going to need to get either IM hydrocortisone, you can get IV hydrocortisone, you can get buccal hydrocortisone, you can get PR hydrocortisone, you need hydrocortisone in some capacity. And somebody belonging to you needs to know you're on steroids. So if you get hit by a bus, God forbid, you rock into me in ED, I need somebody to be able to say to me, he's on steroids. Well, I do that kind of days. Now, everybody really should have one of these bracelets on them or a pendant, just to say that they're on steroids. Same for diabetes, same for anaphylaxis. And you get them in different forms. You can get them in the chemist. Some of them, like this one here, have a telephone number on them with a list of diagnoses. And you ring the phone number and you find out what someone's on. Some just have steroids. Others have a little, it's like a locket, and you pull out this big string of paper, and written on it is all the different drugs that someone is on. I don't really like those, because when you open them out, what happens is it breaks off from the actual locket, and to get it back in again, it's like a 20-minute job to fold it all up and get it back into the little locket. But either way, you do need something. You can get an app on your phone as well that doesn't need to cross the code. It just comes up on the phone that the paramedics can look at to say, I am on steroids. But the only thing is that there's a lot of young people with that, or they don't particularly want that every time they leave the phone down in the pub on the table, it flashes, you know, or you can see on it that I am on steroids, you know. It's a slightly tricky one, but there certainly is out there, that you can bypass the thing. Now, if you're tapering someone like me, after 24 years of steroids, I genuinely, and we've had this conversation with Evan, you've got that for a number of times, you know, I'll do my best, Neve, but I am not a miracle worker. If you've been on adrenal suppression for 24 years, I don't know that there's anything left in those adrenal glands. But you know what? We'll give it a punt. We've given it a punt a few times. But anyway, if they're on over 40 milligrams, I mean, they're way up there. You're on a big super physiological dose, so you can taper quite swiftly. You can bring it down swiftly. So you can bring it down 10 milligrams a week, you know, down to 10. After that, or even down to 20. And then after that, I'm slowing down. So I taper very quickly in the high doses. Then as I come 20 to 40, I taper slightly slower. Then 10 to 20, I'm starting to taper slightly slower. 5 to 10, now I'm starting to taper quite slowly, because 10 is my sick person dose and 5 is my normal dose. When I come to 10, I'm going to go down 1 milligram every 4 weeks. We'll go slowly. And if you're not feeling right, we're going to go back up again, and we'll come down again and again, and do it really, really gently. And if at any stage you're not feeling right during that, or you're feeling that you're deficient, you go right on back up. And if you're properly, like you think you're actually sick, then you double it back up again, and we go down again when we get there. So it's very, very slow. Less than 5 is my floor. Less than 5, we're doing it really, really super gently, and we're really, really aware that as we go down there, we're needing our adrenal glands to kick back. So if they've only been on steroids for 6 months, you know, it probably will kick back fine. But Neve now is a different kettle of fish. The other thing that can sometimes scupper is the underlying disease. What's happened with her is the sarcoidosis come back when they've tried to taper before. Sarcoidosis flared up, so the polymyalgia or whatever it is. It's just to keep that in mind, that that's another thing in there in the mix. that you mightn't get down because of the underlying disorder, whatever it may be. And that has scuppered us a few times, and I've tried to get her down. The sarcoids flared up and she's ended up back up again. And then we go down. When you're putting someone on steroids, you need a baseline weight, blood pressure, like glucose or HbA1c. Now the importance of that is that if you push up, steroids push up your blood sugar, I'll talk about that in a minute. Lipids, bone health assessment. Again, anyone who's on more than 3 months of 5 milligrams of pred is going to need bone, is going to need bisphosphonate, calcium, and vitamin D. Psychiatric history is worth a conversation because we certainly see them on the wards going quite psychotic. It can make it feel very strange. There's definitely just to be aware of it. And every 3 months, then you need to keep an eye on, look for signs of Cushing's, look at their weight, their blood pressure, their glucose, the vaccination stand, because they should have their flu, they should have their COVID, they should have their pneumococcal. Now, whether you give them shingles or not, there's no guidelines on that one way or another. But certainly their pneumococcal and their flu are a standard issue. Annually, they should have HbA1c. Now, the problem with Neve is that she's put on so much weight that she's highly at risk. Now, she's only gone down. She's down to 10 of Pred, and Pred-wise, she's been way down from where she was. But it's just her body mass index is so high now that she really is at risk. And the bone density every 1 to 2 years. Eye check. Now, your Specsavers eye check is fine. They don't need to be going to the hospital with it. Specsavers is fine, but there is a risk of that. It's just to make them aware of it on the steroids. We would come across the hyperglycemia very commonly. And the guidelines would tell you that everybody you put on steroids, you should teach them to measure the blood glucose. Now, I don't know about you, we do not have the capacity any more than a man or woman. We teach in every single person that we put in the day ward, the oncology day ward, hand out steroids more than we hand out glasses of water. There's no way in hell we have the capacity. I don't have the diabetes and capacity to do it. So we just put our head in the sand and ignore it. And when they measure it, when they come in here and their levels are high, then we deal with it. If you're going to measure it, the time to do it is your mid-afternoon. So if you take prednisolone first thing in the morning, its maximum hyperglycemic effect is around lunchtime and afternoon, thereabouts. And that's when you get your peak of sugar, and then it should wear away again in the afternoon as the afternoon goes down. So the kind, if it is, and I would get called up the day ward quite commonly for these kind of things, with someone who's on a high dose for a cytotoxic or whatever they're on, and the sugars are coming back to 25. And they've noticed to 25. It's fine in the morning, but by lunchtime it's 25. Now, I suppose the question, common sense I put in there, because common sense being not that common, but the first thing that I would look at, particularly if I'm in the oncology day ward, is what am I trying to prevent here? I get called to the hospice quite regularly with sugars of 20. I'm push to cry right now. What am I trying to prevent in 20 years? So there's that. Just look at the prognosis. And look, what are you trying to prevent in 20 years? Will 3 weeks of chemotherapy and a few high sugars make any difference? Now, it may be that the prognosis is excellent and that they're symptomatic with it, and that's a whole different kettle of fish. But just have the conversation. What is the diagnosis? What do you think the prognosis will be? And is it making them uncomfortable in any capacity? Because sometimes, quite often, I just leave it. You know what? It doesn't matter if I should leave it. I just leave it. Right. So, if I do need to fix it, if they're symptomatic or they have a really good prognosis and they're going to be on a lot of steroids and we need to actually get on top of this, what I would do is for a quick fix is your glycoside. Your short-acting glycoside is really good. You take it first thing in the morning with your pred and it rises with the pred, the two rise nicely together, and as the prednisolone effect wears away, the glycoside is gone. So to rise and fall really, really nicely. And that's a really nice quick fix. For someone who's on, would say 3 weeks chemo and then 6 weeks off and 3 more weeks and 6 weeks off and 3 weeks on and 6 weeks off, which those kind of are same for the sarcoid where it's on and it's off and it's on and it's off. But what we say to them is we tell them how to measure the blood sugar. Measure it if it's over, I'm going to say 15, whatever your target is. If it's over 15, you take a glycoside. If it's not, or alternatively, you take it with the chemo. When you're off the chemo, you don't. It just works for that little period of time. So it works really, it's very handy for that. It's your little quick fix. If you want a quick fix, it's a little quick fix. If they already have diabetes, or if they're on it with heats, then you can consider something like metformin. It can give you diarrhea vomiting, but that aside, it's a good drug to be fair to it. Trouble is it takes a while to work. So if you're already on the steroid for 3 weeks, the metformin might have kicked in that 3 weeks, and then you're off it, and then you've got all this metformin knocking around that you don't particularly want. So that's where the glycoside will come in. But if you're already diabetic and you're on metformin, by all means, crank it up. You can add glycoside for the little spurts if there are particular spurts of steroids. If they're already on insulin, you can alter their their morning insulin or their bolus if they're taking a bolus just before. To tweak whatever is just at that midday dose. and then tweak it up and down based on how the steroids go. So it's really anyone over 20 milligrams per deciliter, or if you're close to being a diabetic anyway, and the steroids are enough to push you over. But it just takes a little bit of tweaking, and it's not, 3 weeks of high sugars are not going to. Complications of diabetes are all related to the longevity of the hyperglycemia. A short fit is not really either here nor there. But it's just to have the conversation with them and be aware that they know and you know, and that when the nurses checks it and they find this, that no, actually I have to go to the doctor, or the nurse or whoever, and they would often ring the diabetes nurses over the period of time, just for advice that now the sugar is this, what do I do? So most of the time we occasionally do. It's just to watch for it. Bone health, if you're on more than 3 months, or if you're on more than 5 milligrams, which is your physiological dose, anything over that is super physiological, you do need bone protection. You need proper bone protection. Your calcium, your vitamin D, and your bisphosphonates. Now the difficulty with some of my young ones is the whole pregnancy issue. I'm very reluctant to throwing bisphosphonates in people who could potentially get pregnant, or even worse, who are trying. We just need to ride it out, by and large. The calcium and D are fine. We ride it out until they've decided they've finished their family, and then we go for it. DEXA at baseline, at least you have some idea where your starting point is. And it would not be uncommon for us to find an osteoporosis at baseline before we start at all. And we would have been blaming the steroids had we not gone and looked and found that it was there anyway. And your standard 100%, your weight bearing exercise, you're avoiding your smoking, your excessive alcohol, all of those things still stand, 100% still stand. Right, so Niamh. So 24 years in, I'm not optimistic. So the first conversation I'm going to have with her is about her sick day rules, and she's had this conversation so many times. She's looking at me going, seriously, that's what we've had this conversation. But it's important she knows it. It's really important. And as the dose goes up and down, it's important she knows it. And you can't say it often enough. The next thing I would do is check with her. Because she's BMI of 38. She's a young woman. She's quite likely to get pregnant on me. She's a young woman with a big BMI on steroids. So I think blood sugar is really important, and HbA1c equally. Really, really important. Now, I would have a conversation. This is the other thing. If she wasn't trying to get pregnant, but I would have a pregnancy conversation first. Ozempic is certainly an option because she's heavy. She knows she's heavy. She really, really has been trying so hard and really, really wants to go down. She's done the Weight Watchers. She's done the Uni-Slim. She's done all of that and the cabbage soup diet, all of that shenanigans. She has been there and bought the t-shirt. So if she's not trying to get pregnant, then Ozempic is not a bad option. Now, whether you go for Ozempic or Mounjaro, then that's your other thing. I get asked on the wards of this hospital at least twice every day by a staff member, will I prescribe Ozempic? It is, I swear they're going to put it in the water. It's so common. And I've recently I'm prescribing much more Mounjaro. So I'm doing Ozempic. What I'm doing is I'm starting her at 0.25 milligrams once weekly for a month because of the nausea and the diarrhea that you can get with it. Starting it low. So it's 0.25 for a month, then we'll go up to 0.5 for a month, and then we'll go up to 1. Now, anything over 1, well, to be fair, Niamh is not a diabetic, so she's paying for it herself anyway. It's quite expensive. It's 200 or 300 euros. If she had diabetes, she'd get it free up to 1 milligram, but no more. After that, she has to pay the difference. It can go up to actually 2.4, but you can't get 2.4 pounds in Ireland. Well, they're tricky to get. So up to 2 is dead easy. That said, now maybe it's partly for where we live. We live close to the border. I would have a lot of patients who are on Mounjaro, who is semaglutide, which is your Ozempic and tirzepatide, and it works really way better. It is Ozempic on steroids, if an excuse is fun. It is really, really good. But it is expensive. It's more expensive. Now, my punters go up the north, go up to Belcoo and get it up there. It's not as expensive up there, but they have up the price. But it is your Rolls Royce, to be fair. If they have diabetes, I think it's definitely worth trying the Ozempic up to 1 milligram because it's free to them. If they don't, then you can try the Ozempic. It's a conversation. Try the Ozempic or you go straight to Mounjaro. Most of them will try Ozempic to start with, and then if it's not working, then try and put the Mounjaro to be fair. Now the bisphosphonate conversation is also dependent on her. Now she actually wants to have a baby, so we didn't actually put on Ozempic. Equally, she's not a bisphosphonate purely because she wants to have a baby. But otherwise she would be on a bisphosphonate. That's Niamh, and it's the complications and issues that are for on Niamh. Now, so the reason that I got Niamh in the first place was that they were wanting about a taper, to whether or not we'd get her off steroids. Now, I haven't a wizard. I really haven't a wizard. We're worried about her sarcoidosis relapse, and the chance of her having any adrenal function are not actually affected. So what we do, and we've done this, I don't know if I've done this 4 or 5 times, but anyway, she's on 10 milligrams, we bring her down to 9 for a month, 8 for a month, 7 for a month, 6 for a month. And I say to her, if you're feeling funny, go back up, and we go down again. And when she got to 5, what I did was an early morning cortisol before her dose, and it was 21. So there's no adrenal kickback in this one, which is not surprising. So I'm afraid the conversation really went the leave. Certainly, I'm not saying never, but certainly not now. You need to go back on that. You need to, and if 5 is fine, I'm perfectly happy to have her in 5 if the circumstances will allow. If you're sick, you go up to 10, but 5 is your base dose for now. Anyway, we might readdress it, but I don't think we're gonna get any water on that one. Anyway, prolactin. Now I only have very little on this. I get referred to people with hyperprolactinemia quite commonly. And the commonest cause that I would see are the top two: the oral contraceptive, contraceptive prolactin. No harm, just ignore it. Don't even measure it. It's even better. Medications, your antipsychotics, your risperidone, your olanzapine, your quetiapine, your SSRIs do it, your TCAs do it, your verapamil, metoclopramide, cocaine does it. So it's worth that conversation. They all push up the prolactin. Now they're not going to push it up silly, but they do push it up. Polycystic ovaries is the other thing that does push up prolactin. Very rarely is it a prolactinoma. Sometimes, but not much. But I do see them. If the levels are very, very high. Hypothyroidism will do it. I have a number of ladies who will get galactorrhea when if they didn't wear any underwear and just wore a kind of a rib jumper or something like that. It was just enough to stimulate the nipple. Shingles will do it nicely. And then it stimulates the nipple. It just mimics a baby sucking and that irritation of a baby sucking. When to do it? If you've got galactorrhea, 100%. Oligomenorrhea, EMA, menorrhea, infertility workups, that's really the endocrine things. If you think it's a side effect of some medication, if they're on quetiapine and you find that they've got galactorrhea, then you've probably got your answer. But the level of it, if it's ours are the nanograms, our nanograms per mil down at the bottom, that's our values. So a very mild elevation, 23 is the normal. So if it's coming in at 50, you know what, lads, I'm not worried about that. If it's coming even at 100, I am probably not worried about that either. If it's over 200 or up to 400, then I'm thinking, right, we need to image this pituitary, we need to go after this. Your low levels don't need anything other than a medication review and an OCP review or a polycystic ovaries review. That's really all you need with them. You don't need anything else. So in summary, no measures. You don't want the answer, don't ask the question. 2 weeks for T4, 8 weeks for TSH, thyroid antibodies, hardly ever. Thyroid ultrasound, even less often. Steroids, 6-day rules, 5 milligrams is my floor. And your MRI for prolactins very rarely, unless the levels are proper high. I mean proper high. I wouldn't be getting MRIs in the all. All right. That is about all I have to say. I think I've run away with my time, haven't I now? Probably. I can see Robert getting restless.
Not at all, Cathy. Thanks very much. Really, you're bang on time, perfect. And thanks for that. Thanks for that run through the various items that you discussed. Super practical, super helpful, really accessible advice. Very relevant for GPs from my own perspective. Lots of things I didn't realise, and I'm sure for our hospital colleagues. Some comments in the chat. I might ask Gary maybe if you'd like to go first, please. Thanks.
Hi, Cathy. Thank you so much for a very, very informative chat. And it's a long time since we were in college together, but just a quick query. I have a lady who has a history of hypothyroidism, is on Eltroxin. TSH went a little bit low, so we reduced the Eltroxin a little bit, and her TSH went up to 3.98. I was just checking her record there. She came in an absolute storm, giving out, saying that the relative euthyroid state precipitated a lot of hypothyroid type symptoms, weight gain, depression, lacking of energy, motivation, and made her menopause symptoms considerably worse. Quoted some UK specialist who states that postmenopausal women should have a TSH in the suppressed state up to 0.1, and suggested the use of T3 in combination. I referred her to UHG, but she hasn't been called since. So she's currently at 0.15, but she won't go any lower or any higher.
If you ever take thyroxine, it's actually a lovely feeling. It's a nice buzz.
Yes.
And I find this with the thyrotoxics, when you bring them down, they don't like it one bit. So and it's the fluctuations of it more than the level that seems to make people feel miserable.
Yes.
I would hold my ground. If you run her at a low TSH, you're going to give her the risk of osteoporosis and atrial fibrillation. She's going to come back with all of that. This is menopause, anxiety. Oh, it's a slight change. It shouldn't be enough. I don't think it's enough. I wouldn't be. Now you can give her T3 if you want, but I wouldn't be inclined to give her T3. But it's very difficult when they're standing there and they're ranting and raving at you.
Yeah.
I do. To be fair, I do have a number of people who I end up putting on T3 because I can't be listening to them anymore. And I do, and it's not necessary. And I pull back the T4 and I put back the T3. Listen, if this just makes you happy, let's just do it.
Okay.
That's where you end up. But I think you've done absolutely nothing wrong, and I think you are 100% correct in what you've done. She does not need a change of dose. 3.91 is probably perfect. Now that said, everybody should probably have a thyroid function test done when they're well, because the range is quite broad, and you need to know where you sit in it. And if you normally sit at 0.4, and I'm now running you at 3.4, you might feel a bit funny. So we should have them done when we're well, and then you work to that norm. But equally, the range for thyroid function tests, they did it in America, donkey's years ago, by getting looking at all the thyroid function tests that were done in America and looking at 85% of them and with 85% confidence interval, and that's the range. And by definition, but a lot of those were getting them done because there was something wrong with the thyroid. So I'm not sure the range is perfect either.
Yeah.
Your lady, it's a mixture of anxiety, perimenopause, and the slight change she's probably feeling, and probably attributing more to thyroid than she should.
Yeah.
If you come to your wit's end, by all means put it on T3, but I've been that soldier. I totally sympathize with you, Gary.
Thank you very much. Thanks. Yeah.
Good to see you.
You too.
Thanks, Gary. We will go to Mark's question, but Cathy, it's like you're maybe secretly a GP as well. You're practicing this pseudoscience when it's needed, so that's very reassuring for us. Mark O'Malley, do you mind coming on and asking your question, please? Thanks. Mark might be busy just now. Cathy, I don't know if you can see the chat. I don't know if it's worked. I can
see the chat, yeah.
Oh, sorry, Mark doesn't have a microphone. He did mention that at the start. No bother, Mark. Cathy, if you can see the chat, do you want to take Mark's question?
Where is it? Will you read out? I can see Gary.
No problem. 78-year-old woman, persistent subclinical hyperthyroidism on bloods, T4 21, T3 2.1, SCH 0.04, TRAB 2.17, asymptomatic.
Let's see.
It's Mark's question, so I'm not entirely sure.
Is that what that's supposed to be?
I suspect so.
Okay.
Mark, give us a thumbs up there at least if that's what you're meant to say, unless we're missing some acronym. Asymptomatic, no causative meds. Sorry, I didn't hear that. Mark, it's just SCH. Do you mean TSH or?
ACTH or hardly?
ACTH.
ACTH, yes, TSH. Okay, great. So TSH 0.04. No causative meds, and she's on amlodipine, atorvastatin, calcitude, donepezil, clopidogrel. Very endo referral.
I do somebody needs to see her, because the question is, has she, or it's obviously not T3 thyrotoxicosis, has she got a primary TSH deficiency, in which case you just need to check her cortisol or prolactin, all the other pituitary hormones. I would refer her in, to be fair. Now, a lot of them I hold on to the ones with primary TSH deficiency, and I'm doing nothing with them but seeing them once a year. But GPs get a bit twitched if they're out in the community, and I say to the patient when they get there, when I get them and say, you have a primary TSH deficiency, and I explain to them what that is. I said the only real importance of it is A, that your rest of your pituitary is fine, and usually they are, and B, that nobody puts you on carbimazole for something you don't need. So if somebody comes across this again, you just say to them, I know I have it, I've seen Dr. McHugh and I'm fine. But I see them once a year just as a pure reassurance more the GP than anyone, so I don't really do anything with them. Actually, I do nothing with them.
Brilliant. Great. Yeah, Mark says great. And unless there's an additional question. Also, could you comment on how to manage, in quotations, all the raised adjusted calciums that return on blood results, some with raised IPTH, some without, generally asymptomatic, although I know symptoms can be vague. One obvious solution is to stop requesting SMAC on the request form. Are any of these significant? Question mark.
It depends on how it is. I get an awful lot of them with like 2.7, 2.8. I don't worry about them. I'm not worrying them until they're in the 2.9 to 3.0 range. After that, I'm not worried. If you measure PTH, first thing to measure is a bit D. You want to make sure the vitamin D, because if the vitamin D is low, it'll drive up the parathyroid hormone. So you need to measure the vitamin D first and fix it. At least then give the parathyroid hormone some kind of a chance. And if your calcium is high, the normal response is for your parathyroid hormone to suppress. That's because it doesn't need to drive the calcium, so it should suppress. So if it's not suppressed, it's abnormal. But if it's just a primary hypoparathyroidism, I don't do anything with it. And even I have loads of them. I have tons of them in my clinic. I just see them once a year. Tell them drink loads of water because you might get kidney stones and get a DEXA scan. And we manage your osteoporosis. That's all I do with them. Even the ones that have a number of them that are running with calcium 2.9, 2. Or 3.0. And technically over 3, I should be thinking about parathyroidectomy. And I reckon I don't sell it well enough because very few of them will go for it. Go, doctor, I feel perfectly fine. Why should I bother with that? Which I think is actually a fair point. But if it's over kind of 2.8, I think you probably do need to see them. If the parathyroid hormone is high, because it shouldn't be. But under that, I wouldn't be worried about it. Just to drink loads of water, not to get a renal stone, loads of exercise, use osteoporosis advice, and get a DEXA scan, and you're off and running. But fix the vitamin D in the meantime. That answer now. It's a bit bigger topic than that to answer in a few sentences. That's a general.
No, that's great, Cathy. Thanks for that. And we're just getting to time, so I'll just thank you again, Cathy. I found out, as I said, so informative and helpful and practical. I really